Sorry.
So that's fine. This is the first. Do you want me to? You don't want me to start again, I presume.
No. No. It's all good.
Okay. So this is the first icebreaker. I want you to either scan that code or text. You can text me. I'm just going to toggle out of this, and you can send a text to this number 37607. And in the topic of the text, or in the text, you write Maggie Larché 475, and then your answer to this question. Or you can do it by scanning that QR code, or you can do it by going uh, into your internet browser and do it that way. And if you don't want to do it online or through this mechanism, just jot down some words that make you that come to mind when you're thinking here. So I'm going to present this now. So
Can you
come
put
up
up?
with one word that you feel describes the topic of my presentation. Um, are you challenged by it? Are you excited? Are you hopeful? Are you despondent? Yeah, love this. So just keep, we'll keep this going for just a few minutes as you come through. Curious, I love that. Interested, thank you. Excited, yeah, I was hoping that one would come up. Good. So that's just the icebreaker. So we'll move on from that. I was wondering if challenging and oh, anticipatory, I like that one. Challenging and um, complicated might come up as well, but this is totally fine. So it's a good start. So don't forget how to use that because we'll be doing a few more of these throughout the talk. And I would love to take questions as we go if you want, or we can wait for questions right at the very end, whichever people feel most comfortable with. So another question I would like to pose is why do you think meaningful research takes so much time? And we've got a polling question coming up in a minute on that. But there are three main types of research in very broad terms. There's basic science, and that's us trying to figure out who starts the fight in this particular autoimmune disease. Then there's clinical epidemiology, where we're looking for patterns in data that's collected. So the Canadian Scleroderma Research Group, for example, has a really robust track record in multiple publications using the data from those of you who have participated in CSRG. And you might be aware of a SPIN as well, the Scleroderma Patient Intervention Network through Brett Toombs in Montreal. So these are both very robust clinical epidemiology platforms across Canada. And then, of course, there are clinical trials where new medications are trialed in various diseases, including systemic sclerosis. But bear in mind, medications take around 10 years to get from basic science to general use in the population. So it's a very long journey for our patients. And I'm just going to go to the next. So why do you think research is so difficult? What do you think are the factors that play into this, and why do you think it takes so much time and is so sort of burdensome for everybody?
I don't think it's showing up yet.
Oh, thank you.
There we go.
Thanks. Technology, huh? Yeah, funding, safety. Yeah, it's a rare disease, so it's really tough. Um, uh, a variety of populations, having volunteers helping out, whether the drugs are safe, for example, in clinical trials, is always a challenge. It's mostly women. I'm afraid to say there's probably a fair bit of truth in that. And good. So those are all points that I would love to just bring out during the rest of my talk. So thank you for participating and joining me in this. So we're just going to go back to the talk again. So here's some good news. There are many, many sites across Canada doing research. The ones that with the big black stars here are the ones that are already part of CSRG or Canadian Scleroderma Research Group. The ones, but there are multiple other centres across Canada, and I'm not doing it justice because I didn't put stars for them, but many other centres are doing research across Canada. So this is good news. We've got these established sites in CSRG on the left of the screen there, and some new sites coming in 2025, 2026. So I've put here number one is Vancouver. So super excited to have Doctors Hyen Kim and May Kazem joining CSRG, and we'll be asking their patients to participate in CSRG. We've got Edmonton coming on, Saskatoon, Ottawa, and Quebec City. We're also adding a pediatric rheumatology module. We all know that scleroderma is rare in adults and it's super rare in children. But when it does present, it can be totally devastating. The youngest kid I've seen was 7. And I have had other young patients as well. And then we're also considering adding localized scleroderma in, so morphea and other skin dominant diseases into CSRG. So this is just a very brief picture of the different types of scleroderma. And you see in blue here the localized forms. These are patches of scleroderma, thick, tight skin. And they can be patches like the one on the left there, morphea. And they can often be thickened patches which are hyperpigmented, so they're darker than the regular skin. And then there can be this one called en coupe de sabre, or a slash of the saber, which is linear scleroderma, often presents in childhood, but not always, and can lead to certain neurological consequences as well. But the ones that most of us spend most of our time looking at are systemic sclerosis, in the right here in red, and those are divided into limited systemic sclerosis. And what limited systemic sclerosis means is the skin involvement is limited to below your elbows and below your knees, whereas diffuse skin involvement can affect the chest and the abdomen and the trunk and sometimes even the back. So don't forget that both of those types are still systemic sclerosis, i.e., they can affect your internal organs. And then the third category is CINI, or without skin involvement. And I would like to do just another poll in a second just to look at that. So this is the poll. Just have a think about it. I'm going to just put up the slide in a minute. Which type do you have, or does your loved one have? Do you have limited, diffuse? Do you have CINI or without skin involvement? Do you have early, or do you have localized scleroderma? And then the next question will be what are or were your symptoms? Did they change with time? And the point to all of this is that they're similar features, but everyone is different. So let's just go to the next interactive bit. And I would really love your feedback, whether you like this interaction or whether you'd rather not be jumping around. Obviously at the end, because I've done it now. So here we go. What type of scleroderma? So I've got several categories here. Limited or diffuse? Have you got just, not just, but early with puffy hands and no skin thickening? Do you have internal organ involvement and no skin? Do you maybe have an overlap with other myositis like or lupus or Sjogren's? Or really are you not sure what you've got? I think there's also, yeah, there's other as well. Okay, so we've got about a third of each. So thank you for participating in that one. And I will move on to the next one. And what are your main symptoms currently? So this one involves you adding adding to any of these ones that I've already put up, and you can either vote for them and vote for as many as you like, um, or you can also add words to your to your poll. So I've just put a few of the sort of main ones up here, and if you want to add, go ahead. Bumps on hands, yeah. Oh yeah. Skin thickening GERD, ILD, yeah. So the point to this is that there are many symptoms that are really in common to many people: Raynaud's, fatigue, depression and anxiety, joint pain. And then there are several other issues that some people have, some people don't have. And it depends on the type of systemic sclerosis that you've got. So this is really important and very helpful. So thank you for joining in that one. And then there's only one more question left, and we'll do that towards the end of the presentation, okay? Um, so I'm going to get back to the PowerPoint. And we've talked about this one as well. So this is just my table of essentially the fact that there are multiple different clinical presentations in the different disease subtypes and different antibodies that we can measure in blood work. And monitoring is a little bit different. And treatments are a bit different as well. And prognosis is different. So what research is helping us is to define all of these. And this is part of our challenge in basic science, is that there's a massive amount of knowledge already about what's going on in the immune system when it comes to development of scleroderma. We know that there's this autoimmune component with autoantibodies present in most people's blood, not everybody, but most people have an antibody in their blood, like anti-SCL70, for example, or anti-centromere you might have heard of. We know that there's a very large problem with the blood vessels, and that's called a vasculopathy, where the blood vessels get all inflamed and they can clot off. So I don't know if any of you have had digital ulcers, where essentially there really isn't enough blood supply getting to the fingertips, and that's a vasculopathy. And many of us use capillaroscopy to look at those blood vessels. And then the third component is fibrosis and scarring. And the real problem is we don't know who starts the fight at the bottom there. All of these three things, we're not sure which one comes first. Those of us who study the immune system say it's the immune system that gets dysregulated first. The others, people involved in fibrosis or scarring, are much more confident that that's the thing that starts the fight. So trying to tease out the person who starts the fight in scleroderma is really challenging. But basic science does help us. And here's a list of a few of the Canadian basic science researchers. And I've put the CSRG sign next to some of us, just to really highlight that that by no means everybody is part of CSRG, and nor do they need to be, but they're doing really important work at the cellular level, figuring out who's starting the fight. So could it be immune dysregulation? Well, we know this clue from genetics that there is definitely an immune dysregulation component here. A very common question I get from patients and their loved ones is scleroderma a genetic disease, and will I pass it on to my children? The answer is very unlikely, because scleroderma is what's called a polymorphic disease. It's not just one gene that triggers the disease. It's multiple genes and multiple versions of that gene. So that has implications. The different versions and the polymorphisms have implications in which proteins are made by that gene and whether they bind really well to the immune cells, or whether they, and therefore trigger activation, or whether they bind less well and therefore less active or less pathogenic cells that are produced. So this gives us a clue, but we know from genetics, and this is it's called the genome-wide association study that was published about, yeah, I was going to say about 10 years, but 6 years ago now. And what you see is this great big black column, which is the HLA association, and that's a very strong genetic determinant of whether you're going to get autoimmunity or not. And then we get other clues from these other higher peaks that give us an idea of where to start looking for trouble and where to start teasing out the immune system. So this genome-wide association study has been very helpful, showing that both HLA and T cells are really important, and figuring that out is very helpful. So I'm now going to talk about some individual researchers. Dr. Mo Osman is at the University of Alberta, and he has a very robust systemic sclerosis translational research program. He does really patient-focused research, and he takes blood and sometimes invites patients to give skin and a swab from the inside of your mouth to look at markers. And he's particularly interested in a couple of things. One of the things that you all mentioned was a big problem for you is fatigue. And he's looking at whether there are markers specifically for fatigue. And then he's also looking at fibroblast changes in systemic sclerosis, looking at whether the fibroblasts interact differently with mitochondrial, or whether there's a signal from these fibroblasts. And I'll talk about this in a little bit of detail here. So this is his preliminary data, and he's been kind enough to share this with me. This is a cohort of 27 patients with limited systemic sclerosis, but with less than 5 years disease and chronic fatigue syndrome. And then the same number of patients without chronic fatigue syndrome, and then age-matched controls who do not have fatigue. And he looked at 5,400 proteins in the blood, metabolites. And he saw very clearly that in blue here, these people who are fatigued have a very different set of metabolites than patients who are not fatigued. So that gives him a clue immediately that he can start looking at. And I love this thing. It's called a heat map of which patients have the highest concentration. The top here are fatigued and the bottom are non-fatigued. And you see in the non-fatigued group below the blue line here, there's much more blue, and compared to the much hotter, more red signal in the fatigue group. So this is super interesting and gives us a clue about where to start looking. He's also found this simple blood test, which is called polysialic acid, which is found, he was partnering with some cancer specialist doctors, and they found that the cells are coated in this glycan called polysialic acid. And because they get coated in this, they can't communicate very well with their other cells. They can't communicate properly, and that stimulates fibrosis. So this is very again cutting edge, published just 2 years ago now, and cutting edge research that Dr. Mo Osman's doing. This is BC. I wanted to highlight some BC work. So this is from Dr. Dunn, who I believe might be in the audience, along with Dr. Boyang Zheng, who looked at patients' blood again. They looked at 39 patients with scleroderma and interstitial lung disease and compared that to some patients without interstitial lung disease and patients with just lung disease and not scleroderma, and then to healthy controls. And when you compared these numbers, this is just the graphic representation of that, but when you compared the numbers, they found some interesting signals again. So, for example, they found this weird protein that's released from a cell type called eosinophils that's twice as high in all patients compared to healthy controls. So there's clearly some element of the fibrotic disease that perhaps is triggering this eotaxin. IL-6 is 6 times higher in any patient who's got interstitial lung disease, and other molecules are higher. And then this last one, Adams TS13, was lower in all the groups compared to healthy controls. So again, research is giving us clues about where to start looking in the needle in the haystack. What about the blood vessels, so vasculopathy markers? My husband, Mark Larché, and I have spent some time looking at this molecule called CXCL4, and it's very it has multiple effects, including all of this that I've shown on this slide. And the vascular effects are it can generate extra blood vessels in cancer cells. And some researchers have shown from a New England publication, and this is what my husband and I were working from, looking at this very high level of CXCL4, as you see here, in early diffuse systemic sclerosis compared to healthy controls, which is rock bottom. And it seems to correlate with limited versus diffuse and late versus early disease. So it seems to be a marker of early disease and a marker of vascular function. And they also showed that those patients who had high levels of CXCL4 had worse lung disease than patients who had low levels of CXCL4 over here on the left here. And similarly with this other complication of scleroderma called pulmonary arterial hypertension, patients with high levels of CXCL4 were more likely to have pulmonary hypertension. So my husband and I emulated this data, and we showed in our cohort of patients with systemic sclerosis, there was a difference in CXCL4 levels. So number one, it's very important to check your findings against others in the literature. And so this is our preliminary data that we've been able to replicate that. And then we've gone on to work with this guy at the top right here, Dr. Boyang Zhang, who is different to Dr. Boyang Zheng, who is in BC. This guy's in Hamilton, Ontario, where I used to be. And he's been looking at this he's a engineer, bioengineer, and he's been looking at this super exciting model, which has been going around now for probably 8 or 9 years, called an organ on a chip. And what the organ on a chip is a tiny well in a, can you imagine being in a laboratory and seeing this tiny little plate? And what they do is they have channels between the plate, and they put cells of interest. So for example, blood vessel cells or endothelial cells in the middle well of this plate, and then they perfuse your serum from one side and see what happens on the other side of the plate. And they can also look at the shape of the blood vessels. So for example, I'm just going to get my thing out of the way. Sorry. So for example, here, you can see just a twisty curly blood vessel. This one is a blood vessel that is a normal sort of capillary bed, whereas this one maybe looks a bit more like a patient with scleroderma, where if you've ever looked at your nail folds, the capillaries there, they look all very dysregulated and very abnormal. And these are just other types of abnormal blood vessels that he can generate in the lab in this model of organ on a chip. And the super exciting thing about organ on a chip is that they can now connect multiple organs. So systemic sclerosis is a disease of not just the skin, but also the lungs, the gut, the blood vessels, the brain as well, and the kidneys. So we are hoping to be able to connect on a chip all of these different organs, such that, for example, if the serum that I have donated in my freezer, I can perfuse into this organ on a chip through my colleague, Dr. Boyang Zhang. And it's been at least a decade of innovation. And now on the bottom right here, we can do this interconnected organ chips. So my team and I are working on this super exciting element of basic science and how do we make it much more relevant to the patient. So what about fibrosis markers? Again, another CSRG collaborator, Martin Kolb and Shetil Ask from McMaster, where I worked, have shown that there are very clear interconnections between blood vessels and fibrosis in lungs, and they've shown these clear connections. I actually meant to add the results slide here in addition to this, but essentially what I want to say is that there are very clear interconnections, interplay between blood vessels and fibrosis driving that scarring that you all see and are well aware of. I mentioned that Dr. Mo Osman had looked at this type of fibroblast and how some of them share characteristics of cancer. So, for example, those cells from patients with the skin cells from patients with systemic sclerosis, you can throw a whole bunch of different drugs at them that would normally kill those cells. And these cells in scleroderma are not killed. And he's working into figuring out why that's the case and what's driving that persistence of fibrosis. And once fibrosis starts, how do we stop that train? And that's what he's working on. So super exciting stuff. And at McMaster, I'm working with John McDonough, using AI to help us with guiding research. So this is just an example of top left is taking a biopsy and putting it on a slide. So imagine we take a biopsy from your arm and we cut that into very fine sections and put it on a slide. This software called Lazy Slide, which I love the name of, can actually do a whole bunch of different image analyses and come up with where the genes are going wrong, what cell population is the biggest. You can see on the bottom left there, different populations of cells. And it can stain the original biopsy with those different population of cells to tell you where the fight is happening and who's the main player, certainly in terms of numbers. So we're loving using other tools to help guide our research. Moving on to autoantibodies and other biomarkers, Dr. Mei Choi has been working diligently with a company called the Mitogen Lab, which has developed multiple novel antibodies in systemic sclerosis in this Scleroderma panel. So many of you might have heard of your doctor sending your blood work off for the Scleroderma panel. And these are the antibodies that she's testing right now. And of course, some of them, the first line are very familiar to every rheumatologist, but the second, third, and fourth lines are newer antibodies, but they give us an idea of different clinical manifestations or what's known as phenotypes. So, for example, these ones, anti-RP11 and anti-RP155, are more likely to get scleroderma renal crisis, whereas this newer one, anti-THTO, has less skin involvement, but actually more lung and heart involvement. So when we know about these antibodies, we get a heads up about where to look for the trouble in the actual patient. So these are very helpful. So this goes to my point about why is research so difficult in systemic sclerosis. Um, in any complex disease, our understanding of the disease process is really patchy. So, for example, think about your disease when you were first diagnosed. You had Raynaud's, you had tightening of the skin, you probably had a large amount of fatigue. And then as the disease progressed, perhaps the skin softened, and then you got perhaps breathless. And so how do we know when to take blood work from you? And what we're trying to do is narrow down that window of, okay, we're going to get patients just with really, really early disease in the first 2 or 3 years of their disease so that we capture a more homogeneous population. Because as you know, the disease is really variable. So new technology is allowing us to see deeper into the universe and get a more detailed picture, but we certainly don't have all the answers. And I like this one. If we came in a can, on the label of the can would be caution, interpretations may differ, because we all have to interpret our own data and figure out what our own data is telling us. And if you gave the same data to 10 different medical scientists, you would probably get 10 different answers. So we do have to be cautious here. Moving on to clinical epidemiology, that's where we see patterns in large populations of data from patients. And that has definitely led to improved monitoring and improved treatment of patients. And the huge players in Canada in clinical epidemiology have been Marie Hudson, Sabrina Hoa, both of whom are in Montreal, as is Brett Toombs. He's the SPIN director. Murray Barron was the CSRG director for many, many years until I took over in 2021. And he's forged a very firm collaboration with Australia. And Nancy Maltese in Ottawa have been really driving clinical epidemiology forward. And this is just our executive of CSRG. Janet Pope, I didn't mention there, she's also a massive ClinEpi person and drives many, many projects forward. So what about Marie Hudson and Janet Pope? They've looked at this article in the past 10 years using the newer classification criteria of systemic sclerosis, and they showed that those newer criteria were better at diagnosing and figuring out what type of scleroderma the patient had compared to the old criteria. So that helps, I guess, us again put patients into categories and decide and take blood from each of those different categories of patients and look at the basic science level. So this has been an integral. Murray Barron and Marie Hudson, amongst others, have been involved in, for example, finding that there's a very clear occupational pattern in our CSRG patient population. So association with silica exposure. So for example, people who do sand blasting or work in the silica mines up north, and certainly in Ontario. I don't know whether they're here as well. And that really helps us tease out which occupations we need to be targeting and whether we need to be guiding patients, for example, for workplace compensation type scenarios as well. But it also gives us an idea of how to understand what's driving this disease. And then this is just an example of CSRG with a collaboration with the Australian group, looking at how we see the trajectory of each patient with systemic sclerosis. And it really helps stratify and pull out which patients might do worse, and therefore who we have to be a bit more intense with our treatments. Brett Toombs has multiple publications through SPIN. This is just one I pulled out, essentially looking at during COVID, he looked at a video conference based mental health support intervention and found that it was very robust and was able to rapidly deliver this in a scalable way, i.e. he can expand the benefit of this program across the world where his studies are. So Sabrina, I mentioned her earlier. She's phenomenal, young, excited researcher. And she looked at our CSRG data set to tell us that we used to think that ILD was a later manifestation of systemic sclerosis, and you got scarring in your lungs the longer you had systemic sclerosis. But she found that that's not actually true, and that early systemic sclerosis patients are at risk, and those who are at risk are male, non-white race, diffuse cutaneous involvement, arthritis, myositis, and these other markers. So again, it gives us clues about how vigorous we need to be about monitoring and looking at patients. So Sabrina's, for sake of time, I'll just leave this up for a few seconds, but she's not only looking at observational studies and different biomarkers in our CSRG network, she's also running some clinical studies. So for example, in limited systemic sclerosis, she wants to know if we treat the limited disease early, can we prevent disease complications? And of course, because complications take 5, 10, 15, 20 years to develop, these studies are difficult to do because they're very long term. And most pharmaceutical companies, are not interested in sponsoring a 20-year study. They want a 26-week study and they want their answer within the year. So these are also challenges, and people were writing funding as a challenge for research, and that's definitely true. And then the next other important study she's doing is she's wanting to treat mild lung disease in patients with scleroderma to see if she can prevent lung damage. So she's going to trial mycophenolate mofetil versus placebo, because normally we wouldn't treat the really mild disease. And she's recruiting in 3 sites in Quebec for that. So super interesting stuff. Moving on to University of Toronto, I didn't want to leave them out. They've got a very robust clinical data set from Toronto, and they looked at theirs to see whether there were, for example, ethnic variations in systemic sclerosis disease, different types, and what their survival was. And you can see here that, for example, these are all the different ethnicities, and there are fewer patients in some of these disease subtypes, so you have to take it with a little grain of salt. But you can see how different ethnicities have better or worse survival with systemic sclerosis using this data. And Dr. Sindhu Johnson, something that's really close to my heart right now is looking at employment outcomes in systemic sclerosis. And she's just published this review looking at what risk factors are there for disease-associated work disability. This is just a scheme I've stole from her paper from 2023, I believe. It's dear to my heart because if we have this data, we can lobby the government, and we can lobby the government to say, for example, once we know that this is the case, that, for example, if we start these expensive medications early, then perhaps we can prevent work disability, or at least improve on patients being able to continue to work if they want to, and being able to function as well as they possibly can. So this is also interesting stuff. And then finally, Dr. Nancy Mull says, I would say there are several researchers in across Canada. There's off the top of my head, there's Nancy Maltese in Ottawa. There's um, I believe you can correct me if I'm wrong, but Dr. Jan Doets in um, Vancouver, I believe, is working on stem cell, and Caleb Durant in Calgary here is working on cellular-based therapies as well. So Nancy is looking at stem cell transplantation, and then the more novel therapies called CAR T cell therapies and bispecific cellular therapies. And this is just one example, just hot off the press just a few months ago. She showed that with patients who have had an autologous stem cell transplant in systemic sclerosis, she showed that there's clear improvement in both skin fibrosis and lung function. So giving us some hope that the cellular therapies are coming along. I just put this up to give you a little bit of hope that the clinical trials determine whether new treatments improve outcomes. And when I looked at clinicaltrials.gov yesterday, there were 148 studies recruiting across the world, and 321 have already been completed. So this shows you the intensity of work that is going on across the world in systemic sclerosis. So how do we draw everything together? From basic science to epidemiology to clinical trials and to new treatments? Well, I'm just going to give the two examples here in pulmonary hypertension and pulmonary fibrosis. So in pulmonary hypertension, the epidemiology studies have shown that there are risk factors for pulmonary hypertension. Late limited cutaneous systemic sclerosis, patients with large telangiectasias, anti-centromere antibodies are more at risk. This vigilance study showed us that they separated patients into two groups. One just was regularly monitored like most of us do with echocardiograms annually. And if they found high pressures on echo, the patients got a right heart catheter, which if that showed pulmonary hypertension, the patients were treated with sildenafil early. Compared to the second group who they just did not treat or monitor, they just waited for symptoms of right heart failure, like shortness of breath and swelling in the ankles. And then they did an echo and then they treated, and they showed that those patients who got treated later had a worse outcome, and they required two or even three therapies, not just one. But having said that, we usually use combination double or triple therapy up front in patients. And this is informed by the basic science. So I'm not going to go through all of this. You'll be probably quite pleased to hear. But there are at least three different pathways leading to pulmonary hypertension, and we can target with drugs each of those different pathways, and that's what we mean by two or three different mechanisms of action. And that then got translated, knowing the mechanism of action of why pulmonary hypertension develops. There's this new drug that gives us a bit of hope, which is sotatercept, which has a different mechanism of action. And there are two very recent New England Journal papers which shows that this drug not only improves a functional thing called 6-minute walk distance, but it also improves breathlessness and reduces a biomarker that you can see in the blood. And then moving on to pulmonary fibrosis, again, there have been two very recent New England Journal papers that show the mechanism of, or the pathogenic molecule that drives part of the fibrosis is this molecule called PDE4B, and they can inhibit it using this drug called nerandomilast. And they showed that they essentially showed, as you see on the graph on the left here, this is placebo, no treatment, and lung function declines with time. This is 1 year over here on the x-axis, and they showed that both both drugs of nerandomilast, both doses, it prevented the same decline in lung function. So just moving on in the last couple of minutes into new targets. There's loads of hope. Again, you'll probably be pleased to hear I'm not going to go through this in detail, but there's lots of different molecules, and in orange are the potential new drugs that can be available to try and target each of these molecules that is involved in the vasculopathy, the immune dysregulation, and the fibrosis of systemic sclerosis. And this is also to give you a little bit of hope. This is from a paper, I think, published in 2022, showing a list of new medications that are being trialed currently in systemic sclerosis. Again, not going to go into massive detail. So, my take-home messages really are that this is a super variable disease, and that makes studying it super challenging. But we're trying to dissect out who starts the fight, and that's what basic science does. Epidemiology looks at trends in data and how groups of patients with the same type of disease develop complications or not, and whether treatments work in some patients and not others. And clinical trials then obviously are the ones that develop whether that medication is useful. So there is hope on the horizon, and I'd like any of you that want to get involved in any type of research, please do. I like this. I love the cloud and the light. So we need this shining array of light in these diseases. So thank you very much. I'll be very happy to take questions in the last 10, 15 minutes or so. And I think I have one more poll, so I'm going to get that while we're thinking of questions. Okay.
Oh,
So
one
yeah,
sec.
go ahead.
Sorry, we are going to ask some questions. I'm just going to put this up so that you can see who's talking to you. And
Okay, so while we're taking questions, if you want to, this is a quiz because this is the only kind of serious part of the quiz that can give you a challenge for whether you were paying attention.
yeah, are you ready for the questions now?
Yeah, it's great. Sorry, I'll just wrap up. It's just great to see that, of course, there's scarring and fibrosis. There's the blood vessel abnormalities of vasculopathy. The immune system is definitely skewed. Genetics and environment are all part of this picture. And so that therefore, those of you who said all of the above are correct. Okay, I'll get back to the presentation. So yes, I'm ready for questions.
Today, sotatercept has been a large topic of discussion in the PH space as we're getting it approved and everything. Are you able to elaborate on why somebody with scleroderma but without pulmonary hypertension wouldn't be able to use?
I'm really sorry, I can't hear. I really can't hear. So if somebody near the microphone can repeat that question, or take a microphone or whatever you've got to. I couldn't hear at all.
Can you hear me now?
I can see the audio thing going up when you're talking on that one, but the thing's behind us. So yeah, so I'm tethered.
The laptop.
We will come to the computer now.
Oh, can you hear me now?
I sure can, thank you.
My name is Kate. I'm a pulmonary hypertension patient. I was wondering, because we're talking so much about sotatercept right now as we're trying to get it approved, why scleroderma patients without pulmonary hypertension wouldn't be able to use sotatercept, if you know.
Yeah. So, what do you mean? Use it really early before pulmonary hypertension develops?
Or
Is that what you mean?
or even like if it can be used to treat scleroderma separately.
So they haven't done that study, and Health Canada will not approve it if they haven't done that study. And pulmonary hypertension's a big group of diseases that drive pulmonary hypertension, not just systemic sclerosis. So the real challenge is getting the pharmaceutical company to do the study, which then Health Canada, if it were a positive study, Health Canada would approve. So that's number one problem. And number two problem is that these drugs just take a long time to come in to, and they cost a fortune. I don't know, 20 years ago, it was 10 million for a drug to actually get to market. So that was a long time ago. So I should think it's doubled or tripled. So yeah, so I am super interested in using that drug, and actually, I've approached the pharma company to ask them if I can have a tiny sample of their drug to run through my modeling, because if we can show that it inhibits the vascular remodeling that happens in patients from patient serum that we've got from very early disease, then I think we might get some traction. But the Health Canada and the FDA only approve drugs after there's been a proper clinical trial.
Thank you.
Anyone else?
Thanks for the question.
Other question? Okay, come on over.
It's a fully interactive session. You have to come to the
Yeah.
mic.
You know what? We needed to get up and move. We learned
There
about
we go.
here
Yeah, exactly.
after snack. Okay.
The question is, so recent, like global events, especially in the US and all that, it's to me, which I don't follow politics a lot, it feels like there is less money going into research. It's being pulled out. I know you're in Alberta, and I heard also similar talks potentially. Do you think that is going to affect your or our, I guess, our field, or not really?
Yes, I do. It's certainly inhibiting collaboration with America, of course. The national funding for scientists in America has all been completely pulled, so they have no money currently. In Canada, we're a bit protected, thank goodness, because we have the CIHR, which is the Canadian Institute of Health Research. So we still have funding available there, but there's this when I write a grant and submit it to the CIHR, it takes me a month to write the grant, and I have a 7% chance of getting that grant. So it's really demoralizing trying to find money from governments. So sure, I think it will have a knock-on effect, but what we're hoping actually is it will bring American clinician scientists up to come and want to work in Canada. So we may find that although we might be impacted by the budgetary constraints, we might get a brain drain in the correct direction coming from US to Canada. And we've already had a few people inquire about moving over. So some more hope.
Hello.
Hi.
You had one of the items on who started the fight. It was number 3, and you didn't really talk about it. Do you have a few words you want to say about number 3 and who started the fight? It was the bottom
So
one.
the fibrosis
Okay.
probably.
Yeah.
Yeah, I mean, I did go through a few slides on fibrosis and the polysialic acid. And actually, this shows my bias a little bit because I feel that fibrosis is the last thing that happens and not the first. But no, there's tons and tons of research in scleroderma, but also in this condition called idiopathic pulmonary fibrosis, which is a really devastating lung disease. I'm just digging up that slide of who starts the fight.
Yeah, if you go back to, I didn't think it was the fibrosis. I thought it was something else.
Yeah, so there's I'm going to screen share again if I can. Um, was it this slide?
Hang on one second.
Hang on,
Oh,
we need to see it.
There we go.
Nope, it was just the one before they were fighting.
This
It was
one.
That, oh, I guess it is the scarring. So
Yeah.
you're talking about scarring in the lungs and everything already, or scarring in the body, an injury to the body? That was really my question.
Oh, so that's a really good question, and actually, there the what we know and what you probably remember when you first were diagnosed with systemic sclerosis is there's this big inflammatory response where you get the puffy hands and often very itchy skin, and it feels, patients tell me they feel really inflamed. So what we think happens is that inflammation and the immune dysregulation triggers the scarring. So if we can, and I've got a very different attitude towards scleroderma than many experts across the world, and that is I like to start treatment on patients on immunosuppressive treatment early. And when I'm seeing them at that puffy hand stage, even before they've got skin involvement, because my view is that as soon as you see skin involvement, you start getting the GERD or reflux, you start getting bloating and constipation and diarrhea and the GI manifestations. And my view, although I have heard to the contrary, my view is we should be treating this inflammatory response early, because I do not think we can get rid of a scar once it's happened. Some of my fibrosis expert colleagues disagree with that. They feel there is hope to getting rid of the scarring. So for my next presentation, I'll make sure I add a bit more on the fibrosis so that it's better balanced.
Thank you.
Thank you. Are there any other questions? I think not. Oh, we do have one. Okay, hang on. Would you mind just not sharing your screen anymore? We'll just
Oh, yeah.
get a bit better.
Me again, sorry. How do we know that, like, I would like to be part of the, I want to help, right? And so how do I know, how do I be part of the research, or how do I know that my doctor is being part of the research? Should I talk to them? I don't know.
Yes, so always talk to your doctor. If you're under a scleroderma specialist, that helps dramatically. If you're under a general rheumatologist, that's a little bit more challenging. Most of your scleroderma expert doctors across the country have research interests. Dr. Dunn is a really good example of that, and Dr. Boyang Zheng. So there will be opportunities to participate in research, irrespective of whether that's CSRG or not. SPIN, I believe you can self-refer to SPIN, which is this scleroderma patient intervention network. I believe you can self-refer to that one. And talk to your doctors if they want to get involved with CSRG. We're just about to relaunch after unfortunately long hiatus with challenges of me getting the data from the university, McGill University, which would not release the data to me because I'm not part of McGill. So it's a long and boring story about why it's taken us so long to get going, but we're open to new centers. We have a little bit of funding that can help start new centers up, and we're a super collaborative group of mostly, not me included, but mostly young investigators who are super excited.
Dr. Dunn? You want to take a chair? You might be here for a little while.
Okay, this is good. We're gonna have a
Doctor,
one-on-one.
it's nice to see you.
You too, Dr. Dunn.
Almost in the flesh. The only
Yeah.
disappointing thing about your talk is that you're not here.
Oh, thank you. I appreciate that very much.
So I really enjoyed it, and I really like the way you did it. And I'm on your side. I believe in early treatment and be aggressive and do it often. So there's certainly we agree with that. The second thing is for the people here, SPIN exists in Vancouver. You can talk to Fran at Pacific Lung, and she will get you onto the SPIN site and get you if you need their support. I used to run it, but I'm not doing that anymore. Dr. Kim now is running SPIN, and she's also running CSRG. So,
Yeah.
and I have to tell you about Dr. Larché and CSRG. You think she talks blasé about how there's a center here and a center there and a center somewhere else. There were centers nowhere. They'd all died. They hadn't died, but they had disintegrated in terms of a commonality. And she brought them all back to together again. And she deserves incredible credit for that.
Thank you.
I would
That's
consider,
lovely.
I would consider that her first miracle. And I don't know her very well if that's any previous ones. The second one will be with so much cooperation and how well you're organizing the cooperation, how much really first-class work can be done in Canada now.
Yeah.
I can't wait to see. So
Yeah, thank you for that point. I'm super excited about that first class work that already is happening in Canada, and we're just joining up now, and we're really going to explode. And I agree with you. Rheumatoid arthritis 25 years ago was treated with methotrexate alone, and now we've transformed lives of patients with rheumatoid. I firmly believe we're here at that. We're poised now for treatment in patients with systemic sclerosis, like we were in the year 1999 for rheumatoid.
absolutely. So I'll stay tuned. And of course, I hope the more cooperation we have between Calgary and, except for the climate, and Vancouver, the better.
Well, thank you for that. I'm excited about that. I'm just going to say one word, and it's sunshine.
We don't have that here anymore. Come back in February.
Yeah.
Okay. Okay, I think that is it.
Can I do this one?
Yes, yeah.
Okay, hi. Yeah, I'm gonna move back to the audience. Excuse my back. Okay. Thank you so much, Dr. Larché, for providing such a comprehensive and engaging update on current Canadian research in scleroderma. Your presentation highlighted both the progress being made and the important role patients play in advancing research. I really appreciate the hope you provided with the update on the research, which as a person with scleroderma, hopefully will lead to lots of improved treatment for us. We really appreciate your time and the most valuable insights you shared with us today. Thank you very much.
Thank you for inviting me. I've really enjoyed this, and I would honestly love any feedback you want to give where I could have done things differently, better. Did you like the poll or not? I'd love any bit of that feedback would be great. Have a wonderful rest of your day.
Thank you.
Bye then.
Yeah, I've got some stuff to say and Cecile does too. You're gonna do a closing statements though?
Yeah.
I don't know. Yeah, I'm a bit scrambled. I just want to